So today we're going to look at just a couple of drugs that have been used for the treatment or the management of some of the more commonly encountered eating disorders. First drug we're going to talk about is fluoxetine. It's under the brand name Prozac. I'm sure you've heard of it. From a mechanistic standpoint, it's classified as a selective serotonin reuptake inhibitor, or SSRI. And based on this, what happens, and I have a depiction showing this in the next slide, but essentially when you give this drug, there gets to be more serotonin in the synapse for longer periods of time. And then that's thought to kind of balance mood, and we know that a balanced mood kind of affects behavior, which is why from a clinical standpoint, this drug is kind of like the mainstay treatment modality for depression, for anxiety disorders, which we'll talk about in the CNS course coming in April or May. And then from a nutritional standpoint, or from a eating disorder standpoint, it's been shown that specifically high doses of fluoxetine, upwards of 60 milligrams, have worked really well for patients with bulimia. And this came about based on a clinical trial, which is listed right here at the bottom. So this is how SSRIs work. Here's your serotonergic releasing neuron. Here you see the serotonin reuptake. They're calling it a channel, but it's really a reuptake receptor. It's fine, it's the same concept. This drug goes in and blocks this channel, and this channel basically exists to recycle extra serotonin within the synapse. And so when the concentration of serotonin gets really high in here, it through Brownian motion, it comes and it binds to this channel, and then this activates another cascade this way to restrict the release and the production of more serotonin. So this is kind of like this channel is kind of like a negative regulator. All right. And so what we do is we supply these SSRIs, go in here and they block the channel. Okay. And this basically preserves the half-life of serotonin in the synapse for longer periods of time. So what this translates to from a therapeutic standpoint, more serotonin equals a more stabilized mood, and basically that kind of contributes to the therapeutic success of this drug class. The side effect profile of SSRIs, there's two kind of distinctions. I would call relatively minor side effects: nausea, diarrhea, agitation from too much serotonin in the synapse, sleep disturbances, sexual dysfunction, weight gain. Those are relatively minor compared to the more major or dangerous side effects, which is ironic because even though this drug is indicated for depression, in younger patients it has been shown to increase suicidality. So patients, especially early on in therapy, they have a much higher incidence of suicidal thoughts. And so it's really important to kind of keep a close eye on some of these younger patients when they first go on this drug. Some of the bipolar patients can experience manic episodes, and we'll talk about what that means in the CNS course as well. And then we've already mentioned briefly serotonin syndrome. Any drug that effectively increases serotonin within the synapse can produce serotonin syndrome, and of course SSRIs are no exception. Olanzapine is a second generation or atypical antipsychotic, and it has both dopaminergic and serotonergic blocking effects, as well as other neurotransmitters. We typically use olanzapine in the management of schizophrenia or bipolar disorders, but in patients that have anorexia, it's been kind of used as an adjuvant or suggestive therapy. So it's not officially FDA approved, but it's often tried for these patients. Remember that a major side effect to many antipsychotics, olanzapine in particular, is weight gain. And in the anorexic patient, it's not a bad thing. It's actually beneficial. And other effects, other psychological effects of olanzapine are thought to kind of contribute to basically altering body image problems that many patients with anorexia have, and so this drug helps kind of alleviate those psychotic fixes that can be quite severe in the terms of bipolar disorder and seem less severe in terms of something like anorexia, but still persist. Excuse me. Some of these atypical antipsychotics, such as olanzapine, have affinity for several different neurotransmitters. This is from the Pharmacology Institute. This is a great tool if you ever want to look at some of the neurological drugs. In terms of olanzapine and its effect in anorexia, we would probably argue that these would be possibly a minor effect, and that the dopaminergic and serotonergic blocking ability contribute to the major effect. And of course, this basically just kind of summarizes the weight gain. Olanzapine is notorious for the side effect of weight gain, but in these anorexic patients, it's not really a bad thing. The third drug I want to discuss is lisdexamfetamine, under the brand name or the trade name Vyvanse. This is a prodrug. It becomes dextroamphetamine in the body. Mechanistically, it induces the release of several neurotransmitters, norepinephrine in particular, but as well as dopamine and serotonin. And it assists in the depletion of these neurotransmitters from storage vesicles. There's another mechanism where there is an inhibition of the catabolizing enzyme, monoamine oxidase, or MAO, and I'll show you what that looks like. And so both of these mechanisms contribute to the production of more neurotransmitter within the synapse, and that's thought to basically be the therapeutic success of this drug. Clinically, you see this particular formulation with the amino acid bound to it to treat patients with binge eating disorders. Other formulations of amphetamine have been used quite successfully in the management of ADHD. Adderall is essentially amphetamine. Other drug uses that have yet to be FDA approved for binge eating disorder also include high-dose SSRIs like fluoxetine. And this is what amphetamine looks like from a mechanistic standpoint. There's two mechanisms at work here. Norepinephrine is catabolized by MAO, and so what this amphetamine drug does is it inhibits the degradation, so now norepinephrine sticks around for longer periods of time. And then from a vesicular standpoint, amphetamine contributes to the release of norepinephrine from these vesicles, okay? And it does so in a calcium-independent reaction. And so through these two different mechanisms, what you do is you get an increased amount of neurotransmitter, in this case norepinephrine, but it could also be dopamine as well, but it primarily affects on norepinephrine, and you see a larger amount of neurotransmitter within the synapse. Okay? And then side effects to amphetamines. Minor side effects can include insomnia, agitation, tachycardia, hypertension. Remember, the street name for amphetamine is speed, and so if you think of a patient or a person who's on speed, they'll be speedy. They won't be able to sleep. They'll be agitated. Their heart rate will be increased, and so forth. But it is dangerous. Some of the more major or potentially dangerous or lethal side effects include the induction of a substance abuse type of disorder, because this can be addicting and habit-forming. Patients that have underlying structural heart disease at a higher risk for arrhythmias. And then we can talk about in one of the cases that I think that are upcoming is a patient that presents with what looks like STEMI, but they actually have normal EKG, and what it is it's an acute overdose of amphetamine or methamphetamine speed. And of course, if hypertension can go very high, it can become lethal. So we can put hypertension on both lists. Okay, so this is kind of a nice brief introduction to some of the more centrally acting drugs that we're going to talk about in a lot of detail in the brain behavior and cognition block. But this is kind of a nice foray into that by looking at some of the eating disorders that exist in some of our patients. All right, so please email me with any questions, and we will return to this topic soon.